Welcome to another episode of Progress, Potential, and Possibilities, discussions with fascinating people designing a better tomorrow for all of us. I'm your host, Ira Pastor.
Welcome everybody again to another episode of our show, bringing you another really awesome guest today, involved in creating a better tomorrow. Some really unique topics today that we're going to be getting into that we don't normally touch on, but we have the honor of being joined by Dr. William Padulla, Assistant Professor of Pharmaceutical and Health Economics and Fellow in the Schaefer Center for Health Policy and Economics at the Alfred E. Mann School of Pharmacy and Pharmaceutical Sciences, located at University of Southern California, where his research explores the foundations of medical cost effectiveness analysis, focusing on issues like the value of vaccines, various forms of healthcare delivery, and then really a core topic we'll be getting into today, the area of patient safety in hospitals from acquired conditions like pressure injuries. Dr. Padulla has received grant funding from a variety of sources over the years, including the NIH, the Bill and Melinda Gates Foundation, as well as Pharmaceutical Research Manufacturers Association Foundation Frontier Award, is the author of hundreds of scientific papers on these topics. Dr. Padulla previously held appointments as assistant professor at Johns Hopkins at the Bloomberg School of Public Health in Baltimore, and as a postdoc fellow at the University of Chicago. He's also served as a visiting scholar at the University of York Center for Health Economics of York in the UK, the Oxford Institute of Nursing, Midwifery, and Allied Health at Oxford, and the University of Technology Sydney, Australia. He did his undergraduate degree in chemical engineering at Northwestern, moved on to do a master's in evaluative clinical science at Dartmouth, and then ultimately did his Ph.D. In pharmaceutical economics at the University of Colorado. A lot of interesting topics to get into today. Honored to have him with us. Dr. William Padula, please welcome to our show.
Thanks, Ira. It's nice to be on here.
Great to have you. You know, as I mentioned, a bunch of topics we typically don't go into, but I'm really looking forward to our discussion. But we'd love to start things off as we typically do by handing things over to you for a couple minutes to talk a little bit more about yourself. Would like to hear about the early journey, about obviously you're thinking a lot about bioengineering and sort of all these interesting technologies that you now evaluate from a pharmacoeconomic perspective. But talk a little bit about the early days and a little bit how you made the transition from sort of technology into really evaluating the value of these technologies that are in front of us.
Yeah, thanks for asking about that. It's been a long journey, as you can hear from the bio. Starting off in engineering and ending up where I am today was really an interest in technology and trying to find ways to use what I liked in science and math and applying it in a more social, meaningful way than just building something tangible. So I've enjoyed spending time in healthcare and thinking about how we can help patients get better access to pharmaceuticals, access to better quality care. And that actually all comes from the same mathematical foundations as what engineers use in order to make toothpaste or toilet paper or oil, all these different products that we use in everyday life. And it was a fun journey to go through the process of learning engineering and then applying it in healthcare and health systems. And that's where we are today, where I really spend most of my time actually looking at the economics of some of those other health technologies you mentioned, like vaccines or new pharmaceuticals that cost $1 million but can cure sickle cell disease or cure hepatitis C virus, that these are amazing technologies coming through the pipeline. Of course, we have to pay a lot for them. And the question always comes up is, how are we going to pay, and is it worth the money for the value of these new health technologies? So I spend a lot of time building economic models that frame the system around the technology that's being implemented in health systems, and try to understand the cost effectiveness of those drugs, of those biomedical devices, of those new procedures that patients can receive. And these ultimately help us think about, is it worth our money as taxpayers to fund through Medicare patients' access to these new, more expensive drugs? It's really important because Medicare doesn't have a blank paycheck. Sometimes we think it does, but it really is constrained by its own budget that's allowed by Congress, of course, and the same with the Medicaid program. So whether we're talking about seniors or we're talking about lower income individuals in the United States, that both of these programs are constrained by taxpayer dollars. And so if I were to say to Medicare, you should spend on the hepatitis C curative treatment that companies like Gilead produce, then it draws funds away from being able to invest in other opportunities, like a cure for cystic fibrosis for children, for instance, or like I said, a gene therapy for sickle cell disease for an underrepresented minority populations. So these are decisions that we make in economics, referred to as opportunity costs. Opportunity costs in economics stand for spending on the next best alternative. And really where rubber hits the road in today's conversation, we're talking about, I'd say, a less sexy topic than vaccines and gene therapies when you talk about wounds, but as a matter of fact, this is a $50 billion issue just for the Medicare program in the United States. And so whenever a new technology comes along that can help better manage patients with these chronic wounds like diabetic foot ulcers or venous leg ulcers or pressure ulcers, that these conditions that add up to $50 billion in taxpayer money, if they can be managed with a better technology that helps the patient heal faster and keep them out of the hospital over the longer term, then that's good value for money. And that's where I come into play with helping decision makers think about whether that's money worth spending on. And that's kind of been my vibe over the last few years. How I got into all of this work in chronic wounds, I actually started it as a grad student where I was looking at cost effectiveness of treating and preventing pressure ulcers or pressure injuries or bed sores, as you might hear them, which are commonly occurring among patients who are bedridden in hospitals and in nursing homes. And we spend $30 billion a year just on treating that one little condition that few people think about. And normally it goes by the wayside, I think, because it's the elderly who are in nursing homes who already have a number of other complications. And so their chances of survival are smaller than they are for most patients who we're treating. And I've come to learn a lot about chronic wounds through that early graduate work in pressure ulcers and applied it to these other areas of chronic wounds as well. So it's been a long journey there.
Yeah. No, it's interesting because, I took a look at your PhD in 2013, comparative effectiveness of quality improvement interventions for pressure ulcer prevention in U.S. academic hospitals. And, aside from, you studying, as you were just mentioning, all the various quality improvement interventions to deal with, preventing this $30 billion basket of stuff that's happening. Sure. A lot of what was happening back then and prior, and I'd love you to walk through this before we get to our core topic, because if we go back a few years prior to that, to I believe it was 2008, that's when we had the first rumblings that, hey, Medicare and Medicaid were not going to be paying for what sort of top of mind to someone like me that interviews a lot of folks on the cutting edge of these different technologies. It's okay. I mean, we had a good process for dealing with these things for a while now. This isn't like a new technology, as you were just saying, not boring, but nonetheless a sort of low-hanging fruit that was working. What happened in 2008? And relate that to 2013 and your dissertation, and then we'll move on to the other.
That's a good topic that you brought up, that knowing about the history of quality improvement really does matter. And in fact, I'll take you back to about 1996 to 1998, when the U.S. Institute of Medicine, now it's the National Academy of Medicine at the National Academy of Sciences in Washington, they wrote this series of really profound reports, First Do No Harm and To Err is Human, that really helped us to understand that because medical care is delivered by people, it's natural that people make mistakes like they do anywhere else. And we need to put more effort into redesigning the system to accommodate for the fact that humans are humans, and we do make mistakes, even though we always try our best, especially I think in healthcare, and try to have the system capture those mistakes before they end up on the patient's bedside and can cause greater harm. And so this led to this whole movement, of course, of first establishing evidence-based medicine as the standard of care, that doctors and nurses and therapists and other types of clinical providers shouldn't do something for the patient unless there's evidence that it actually does work. And so in the absence of showing evidence that it does work, you shouldn't do something, put something in a patient's body you wouldn't put in your own body, let's say. That's the evolution of those Institute of Medicine reports. And so, of course, you see throughout the late 90s and early 2000s, this explosion of research in healthcare. When you look at the numbers of papers published in the National Library of Medicine database, PubMed, it went from being hundreds of thousands of papers cumulative in the history of medicine back through the 90s to multi-millions of papers being published. So we have a lot more evidence today than we did at the beginning of that. And I think that was part of the push to expand funding through NIH and the Agency for Healthcare Research and Quality and other like-minded institutions at the time. Of course, as the evidence base came along, what was interesting is small groups of physicians, of podiatrists, of nurse researchers and physical therapists in this field of wound care started establishing specific evidence-based measures and routines for preventing pressure ulcers or treating diabetic foot ulcers and venous leg ulcers. And so this was all working in parallel with this large push across healthcare. And that came to the realization that most of these conditions were entirely preventable or treatable so that you prevent the next serious consequence, like an amputation or a wound that leads to an infection that can cause an early death, like it did for Superman, Christopher Reeve, who actually died of an infection related to a pressure ulcer. So you have the story of these conditions and how to prevent them. And Medicare actually took notice. So in 2008, Medicare announced that it was going to begin withholding payments for preventable hospital-acquired conditions like bed sores or pressure injuries, and that put pressure on hospitals in order to do the right thing for the patient to prevent the outcome, because if the outcome happened, the hospital is going to have to foot the bill themselves. And they couldn't bill it to Medicare. They couldn't bill it to private insurance companies because many of the private insurance companies were following suit with Medicare's policy here. So it drove the institutionalization of evidence-based practices for preventing the outcomes related to chronic wounds. And so that was an interesting time because it was as I was beginning my doctoral work at University of Colorado. And so I latched on to that policy and studied the policy as it rolled out over the next few years. The non-payment for hospital-acquired conditions was written into law as part of the Affordable Care Act in 2010 when it was rolled out. And so that first 3 years between 2010 and 2013, we really saw dramatic changes in practice. And that's what I studied, where hospitals that were adhering to evidence-based practices by teaching it to their nursing staff and then following up with implementing some of the practical technologies that help prevent pressure injuries, like beds that are air fluidized or have smart technology to actually move the patient about, repositioning regimens, proper nutrition for the patient, and managing moisture and incontinence issues. That all of those steps taken with the right technology can prevent most of these occurrences from happening. And today, of course, there's been other policies that have come along that I think have interrupted the progress that was going in the right direction with those non-payment policies. That actually in 2014, Medicare, in a way, they doubled down on thinking, well, this non-payment policy worked, let's add to it. And so then they began penalizing hospitals 1% of their total Medicare reimbursement if they fell in the bottom quartile when it came to composite rates of pressure injuries and other hospital-acquired conditions. So that meant composite rates of pressure injuries, of surgical site infections, bloodstream infections, catheter-associated urinary tract infections, and deep vein thrombosis, other types of things that are considered hospital-acquired and preventable that, of course, lead to serious infection or a chronic wound that costs more to treat than paying for the prevention up front. And so we saw that during that time, hospitals began to, I think, get smarter at gaming this policy. And so when you think about a composite rate, you don't have to drive down the rate of all conditions in order to achieve a better rate than you did pre-implementation of that Medicare reimbursement policy. And so some of these hospitals managed to grab onto the low-hanging fruit and, let's say, get drive down rates of surgical site infections or bloodstream infections and deep vein thrombosis. And even if pressure injury rates went soaring, the rates of these other conditions would go down and would bring down your average. So you would stay out of that bottom quartile for composite rates of hospital-acquired conditions, and you would avoid a 1% penalty from Medicare for your total reimbursement. Thinking about these penalties, these are significant finances. You know, for a hospital the size of Johns Hopkins or the Mayo Clinic, 1% of your Medicare reimbursement could be $5 million a year. And so they were figuring out that they don't have to get that penalty if they just get down some of the rates. And pressure injuries being more complex, more labor intensive to implement, costly to implement a prevention protocol, it's a tough trade-off to make of whether it's better deal to pay for prevention or deal with just paying the 5% penalty and paying for the fallout on the back end. And especially hospitals these days that are strapped for cash because they might be waiting months for reimbursement from different payers. You know, they don't have the money up front to invest in an infrastructure for prevention. And that's what we started to see around 2014. So today, as far as we know from data from the Agency for Healthcare Research and Quality, despite all of these policies that were implemented to improve patient safety, to improve prevention of these types of conditions, pressure injuries are reportedly higher than they were 5 or 6 years ago. And so what I've said, and many of my colleagues at the National Pressure Injury Advisory Panel have said, is that we're facing a national emergency of these outcomes in chronic wounds. And of course, it goes back to the point that these chronic wounds, they lead to infection. Of course, that has its own risk. They can lead to an amputation. And what research that David Armstrong and I at University of Southern California have seen is that when a patient gets an amputation as a result of a chronic wound, they have the same 5-year survival rate as a patient with cancer. And so this is a remarkable parallel that even though, again, we don't think about wounds the same way we think about cancer or a serious infectious disease or you know, a rare immunological disease, again, these chronic wounds, they cost Medicare system alone $50 billion a year. And then, of course, the amputation rates leading to survival the same rate as cancer. Like, these are concerning conditions that we lose a lot of lives to every year that are otherwise preventable.
And again, I appreciate you taking us through that part of the history. Want to make a short segue now to the area of skin substitutes, because again, this, you know, if we let's sort of look at the broad umbrella that constitutes regenerative medicine or cell tissue bioengineering, we profile a lot of what I'll call sort of the frontier, the over the horizon stuff in terms of, you know, bioprinting human organs and complex tissues and things like that. Skin substitutes, you know, not as complex, been around for a while. They do what they do pretty well. What's happening? I'd love for you to sort of walk us through, you know, a little bit of, you know, just the benefit here, because clearly there's a benefit to these skin substitutes. But if you could introduce us to what's happening per the Medicare administrative contractor system. And this is something, again, we've done a couple episodes with folks at CMS Innovation Center, Liz Fowler, and recently Darshak Sanghavi, who moved over to ARPA-H, again, you know, talking about, you know, interesting aspects of value in healthcare. Explain, because we've never touched on what the Medicare administrative contractor is all about, because that's a separate private healthcare insurer that's making these decisions how does it integrate these three parts? Because these three things coming together are a problem now. So I would love to, if you walk us through each of these pieces.
Sure, there are a lot of moving parts here,
Right.
and maybe I'll just start with skin substitutes in general.
Sure.
And speaking from the standpoint of I'm an economist, I'm not a clinician, so I can't say firsthand that I've used skin substitutes and that whether they work great. But I'm a data scientist, and so when I look at the data, I say, hey, these things work. And what are skin substitutes? They are actually basically stem cells derived from discarded placental tissue that would otherwise be used for no other purpose. And we're able to take layers of the placental tissue as stem cells, apply them over an open wound, and they really become like your outer skin and help seal up the wound and help the underlying tissue that is part of the wound heal up because these placental tissues, they're nutrient rich. And of course, they act as a skin or a surface barrier for the wound itself. What do I see in the data? I see that after, let's say, 12 to 15 weeks, often chronic wounds are healing up remarkably well. And we see low rates of recurrence of those wounds, which otherwise they come back on you when not treated properly, like a diabetic foot ulcer or a venous leg ulcer. The recurrence rates are high in these wounds generally. And of course, that risks readmission for the patient, that they have to go back to these wound clinics or go back to the hospital to be treated. And the high rates of amputation are lowered significantly by the association with these skin substitutes. So they're an amazing technology that have come along over the last, you're right, 1 to 2 decades. It's been a while now that we've been seeing it work, and it really does work because a chronic wound that using other standards of care like compression therapy and bypass surgeries, let's say, and simple debridement, those types of procedures get the wound healed in 25 to 30 weeks on average, is what I think we see in a lot of the data. But when we use these skin substitutes, these newer technologies, we're seeing wounds heal in 12 to 15 to 20 weeks. So the patient is getting healthier faster. There's a higher rate of healing, so they're at lower risk of having a chronic wound that keeps on keeping on through the long term. And then, of course, you see all the other rates of long-term consequences drop. So with skin substitutes, amputations drop, mortality drops. So these are obviously good things. Of course, they come at a cost. And I think it's important to come back to that key philosophy I mentioned earlier. Everything here is not just a cost, it's an opportunity cost. And you have to ask yourself, is it worth it to pay more upfront for a skin substitute that helps a patient heal faster and reduces the risk of long-term consequences versus rolling the dice, using standards of care that are decades old, like compression therapy and debridement, and hoping that the patient gets better, but risking higher rates of amputation, higher rates of infection, and ultimately higher rates of mortality over the long run. And what I've done in my research on the cost effectiveness of these skin substitutes is show that it's more cost effective to use a higher cost technology like skin substitutes upfront to prevent these long-term consequences that Medicare still has to pay for if they occur, like an amputation. And so Medicare, from an economic standpoint, based on academic research, should be paying for skin substitutes thoroughly in order to prevent the long-term consequences. That's science. And so given that understanding, Medicare should be reimbursing fully for these skin substitutes, but what they decided to do in the last couple of years, it's been a long time coming. We've seen this train rolling down the tracks. They've begun to tighten up on reimbursement for skin substitutes. And so now there's a new statute floating around called a local coverage determination, or an LCD, where Medicare's components, these MACs, as you referred to earlier, the local health systems are implementing local coverage determination that would limit a provider to using 10 of these skin substitute applications within a 12-week period.
Mhm.
And so that means that on average, a provider is going to use less than one skin substitute per week, whereas um, the manufacturer guidelines in most cases for these skin substitutes to follow the parameters for use that the provider has established as evidence-based practices. You should be using a skin substitute every 1 to 7 days on the patient. And so if you exceed that 7-day window, which 10 skin substitutes in a 12-week period would do, then you're not following parameters for use, and it does risk the patient having an improvement in their healing of a chronic wound. And there's actually evidence to support there are significant differences in health outcomes when you follow parameters for use by applying a skin substitute within a 7-day period for each patient versus going outside of these parameters for use and letting more time delay in the application of a follow-up skin substitute. That patients don't heal as quickly, they have higher rates of infection, they have higher recurrence rates, and they have higher amputation rates. And of course, by the time you get to amputation, the rest of the story is written that mortality can increase significantly. So Medicare, in my opinion, has overstepped the evidence and established a policy for reimbursement that I'm concerned could harm the patient. And it takes away provider autonomy, that providers should have the opportunity to work with the patient directly on a care pathway that is best for them. And if you need to apply these skin substitutes every 3 to 5 days, then that must be based on some intuition or training of the provider to know that the patient will get better, and that intensive therapy over time will lead to safe healing of a chronic wound. So I'm going to put a pin in that for a sec and go back to another history lesson in public health for you, which is this famous paper from 1973. It was by Jack Wenberg and Alan Gittleson, called Small Area Variation in Healthcare. It was published in Science, which you don't get a lot of public health papers published in Science. So when there is one, you ought to read it. It's a great paper, the Wenberg and Gittleson paper. And what that paper established for the first time, actually, it was a neat study about tonsillectomy rates in the state of Vermont across different counties. Wenberg and Gittleson, they're famous professors up at Dartmouth College. I actually got to learn from them when I was doing my master's degree. And they studied locally the rates of tonsillectomy in different counties across Vermont. And what they found was that there was no consistent pattern across counties in Vermont, that if you grew up in one county, you may have, the rates of tonsillectomy may have been non-existent. But then if you move slightly over to another county, then suddenly every kid in town is getting a tonsillectomy. It made no sense. It certainly wasn't consistent with the rates of what students actually might have, or kids actually might have had inflamed tonsils. And so what they began to realize is that the small area variation in tonsillectomy rates was based on where the provider trained. If they went to University of Vermont, they may have been taught by a surgeon, like, take out the kid's tonsils as soon as you can. And then other doctors who trained more on the east side of the state, by Dartmouth or by some of the Boston medical schools, might have been taught more conservative methods. Leave the tonsils in as long as you can. And so that small area variation was dictated by where you trained. It's dictated by reimbursement policy. And that 1973 paper came up with this very interesting map of changes in rates of tonsillectomy. So thinking about reimbursement policy is not consistent in healthcare across the United States. It's very dotted. That in some states like Florida, you get more money for a hip replacement than you do in Minnesota. And so what we begin to see is that the care that's provided to patients is supplier sensitive. And by supplier, I mean provider, I mean doctor or physician assistant or nurse practitioner or podiatrist, that all of these care providers are actually influenced by the reimbursement system that they work under. And it's an inherent bias that, of course, if I get reimbursed more to do something, I'm more likely to do it, and I'm more likely to do it often. And the challenge with now I'm zooming back in on the topic here with chronic wounds intentionally, that the challenge for providers is that when Medicare was writing a blank check for skin substitutes, that providers that treated patients with chronic wounds had every incentive to use these skin substitutes as much as they wanted, right? That you maybe trim off a little more tissue. If the patient could afford the time, that you'd invite them back into the office a couple days a week. And so some may argue that certain providers were using skin substitutes like candy on patients over the last 20 years because they get reimbursed so well by Medicaid for using it. And that all is based on the argument by Wenberg and Gittleson and small area variation that suppliers are able to induce care, and that inducement of care receives a greater reward in a fee-for-service Medicare system. So obviously, Medicare is responding to the situation by saying that those providers who overuse skin substitutes need to be drawn back. And this policy that they've instituted or recommended as a local coverage determination for 10 applications until 12 weeks ensures that this is all you're going to get. But the challenge with that local coverage determination, again, is it goes against all the evidence to date that exists on the application of skin substitutes following for parameters for use. And so I think where Medicare is missing the point is it's fine to create more specific reimbursement policies, but don't go against evidence-based medicine. That there's an opportunity here to find a middle ground between total overuse of skin substitutes and establishing a reimbursement policy that follows parameters for use. And that can be within a certain time window, of course, like 12 to 15 weeks, and ensuring that within 12 to 15 weeks, a patient gets at least 1 per 7 days. And in a special case, perhaps there's a way to institute other codes that would help Medicare identify that the uniqueness of the patient case allows the provider to work with them on more dressings. But you have to follow certain appropriateness criteria in order to determine that it's valuable for the patient to receive additional skin substitutes. So I think that's where we are today with this Medicare reimbursement policy, that there's a lot of history behind why they would do this based on Wenberg and Gittleson's public health research. And we're at this point today where there's an imbalance between what patients and providers should benefit from in skin substitutes and what Medicare is willing to pay for. And of course, leaving the rest of the cost to the patient, let's say, saying that there's a donut hole past the 10th application of a skin substitute in a 12-week period, I would make a bet that most Medicare patients on a fixed income can't afford skin substitutes out of pocket. Right. So being told the last two for weeks 11 and 12 aren't covered, so you, the patient, have to pull $2,000 per application out of your pocket to pay for it. That puts them in a really difficult position to probably pass on those applications, and let's hope that the wound just gets better on its own, which often it doesn't.
You know, it's as you're going, I really do appreciate the history lessons that you're giving here. But as you go through this, you know, I'm thinking about, and one of the things, and I didn't mention this by one of the things that you're known for is this principle, and you've written a lot about it, called defects in value. That, you know, we have this system where we have potentially high, low, and no value care sort of all together, and we have to tease out portions of that. And I think there was a number somewhere that you talked about $1.5 trillion that we're spending on these defects, and obviously a lot of improvement that can be made there. And as you were just pointing to some of the issues in terms of, you know, some of this group over here that may be overusing these things, and it's hurting everybody else in the chain. What is technology's role, or sort of health tech's role, in sort of curing some of these defects in value? Because I noticed, you know, recently you've written several papers on things like machine learning in terms of predicting the proper patients, you know, that are more at injury risk than others. An interesting paper you put out in terms of mixed reality technologies, again, in sort of the older adult population in certain conditions of this nature. Talk a little bit about health tech's role here in curing some of these defects of value.
Sure. I'll give some general context to defects in value that you touched on to begin with. So we're a $4 to $5 trillion healthcare economy now in the United States. That needle keeps moving up every day. Of course, the paper that Pronovost and colleagues led on defects in value to begin with said that approximately $1.5 trillion, or more than 25%, that we spend on healthcare is waste. It's defects in value. And the idea is that these are things that could be prevented either systematically or through direct implementation of technology with the patient that reduces rates of readmission, that reduces the rates of avoidable complications like these chronic wounds and hospital-acquired conditions, improving shared decision-making, helping the patient and the provider work together towards a solution that the patient would favor, and using high-value sites of care. So getting a hip replacement at a place that does 1,000 a year, not a place that does 1 to 2 a year, has also shown to lead to better outcomes. So those are some examples of categories of defects in value where if we spend on the solution to readmissions or avoidable complications rather than the negative consequence of the outcome itself, then we'd be saving money. And a perfect example in this specific case here with chronic wounds is that I've calculated that we spend about $30 billion a year now just on pressure ulcers in the United States, a completely preventable outcome. Whereas if you instituted the spending on the infrastructure and the resources to prevent these from happening across hospitals and nursing homes in the United States, it would only cost $15 billion. So you can't just eliminate $30 billion in spending altogether. But if we spend actively on the preventive side of healthcare, $15 billion is still a much better deal than $30 billion. There's a lot of things that we could do with $15 billion. We could perhaps, implement policy solutions that improve schools, that get more people better jobs in the United States, that these are the opportunity costs of $15 billion that are real political societal problems that we talk about every day. And so that's kind of where I come at with defects in value. And you could think of the same thing across this class of chronic wounds here, is that not implementing skin substitutes represents a likely defect in value, because if we don't have access to skin substitutes following parameters for use, then we're going to end up paying for long-term non-healing wounds. You're going to end up paying for infections. You're going to end up paying for potentially amputations, and of course consequences of the last 6 months of a patient's life that often are the costliest period of time that Medicare has to pay for. And so if you can suspend that till later in life, it's better for the patient. Of course, we're talking about Medicare patients. My parents at 65 still working in the United States. So these aren't people who are unproductive. Of course, if we can manage their chronic wounds, then they can remain productive members of society. And that doesn't even go into these calculations of defects and value. That raising more money for the GDP of the United States is also a good thing. And many Medicare patients are still of a working age these days. So putting all that together, I guess, with your other question about technology, what are the technologies that can help us improve defects in value, I think is a good question to have asked and answered here. And technology, in my mind, for healthcare comes in 3 forms. The most obvious one is the drug or the biomedical device that is given to a patient, and somehow that technology in or on your body makes you feel better, it makes you work better, and that you're healthier because of it. So we see that every day, where something as simple as a statin that lowers cholesterol to a drug like a cure for hepatitis C that eliminates that infection from your body, or a vaccine that prevents that infection from ever happening in your body, is a good thing. The next level of technology are these diagnostic types of tools, or I call them sort of physician-assisted technology, that by a radiologist looking at an MRI can find out something about you that helps better direct the pathway of care for the patient, that knowing something specific, it leads to better outcomes as well. The third kind of technology that I think is the most undervalued according to the defects and value framework, but has the most opportunity to eliminate a lot of these $1.5 trillion are system level technology.
Right.
And so this gets at actually where you mentioned machine learning, that machine learning gets right into play here with the opportunity to predict what patients needs, that then the health system can be more serving of that patient, right? That me wearing an iWatch or an Apple Watch right now, you know, if that were linked by Bluetooth so that my doctor could see what my heart rate is, or if I was at risk for AFib, then it could see what's going on with my heart patterns, my breathing rate, my activity levels, that all of that information shared with a provider could predict when I need to see a doctor, or when any patient needs to see a doctor. Of course, that's the opportunity here for the system to be proactive at bringing patients in and giving them the treatment that they need, to be more preventive, or as the defects and value paper says, move patients from that state of getting from sick to getting better to staying better, as it's put here, and moving up that scale. So I think that there of course is many different types of technology. I would put skin substitutes in the category of what you put on or in the patient in order to help them feel better right away. But that there are also technologies that are coming down the pike here that can be more systematic as a way of thinking and preventing a lot of these conditions from happening in the first place. That a patient with diabetes doesn't automatically have to end up with a diabetic foot ulcer, that there are ways that we can monitor their activity, their movement, and their daily routines of things like taking their medication adherently in order to prevent the diabetic foot ulcer from occurring in the first place. In most cases, of course, we're talking about the majority of the patients under the curve, and that there's always going to be outliers, that it seems like no matter what you do, they're going to get a diabetic foot ulcer. No matter what they do in terms of not being adherent to their medication, somehow their body is still protective of some of these other health outcomes. So there's two tails to this population curve.
Excellent. You know, we've talked a lot about pressure ulcers, and obviously this is a very important topic in lieu of the issue that you outlined. But needless to say, you're involved in looking at the cost effectiveness of many things, as you were mentioning early on in your introduction. Everything from sort of the multi-million-dollar one and done gene therapies to you know, down the road to vaccines, which I always find interesting that we have to argue whether they're effective or not in today's world. But I did not mention in your bio that in addition to your role at the university, you also are a founder of a consulting company called Stage Analytics that does a lot of work advising pharma, biotech, medical device companies, and so forth. What else are you up to? I mean, your publication history is basically, you know, full of everything. I mean, in all sorts of analyses. What other things are you sort of interested in looking at that you could talk about that are not confidential to your clients, but you know, other emerging topics that yeah, as we get into this era of multi-million-dollar therapies and so forth, that, you know,
Right.
hey, got to spend some time on this stuff as well. So
yeah,
what gets you excited?
I'll share a couple of thoughts with you of what's coming on lately, and it's all relevant to where we started today with wounds, but of course it applies to a vast area of health technology in the space. So one of the first things that I've been looking at lately that I think is pretty cool is trying to get around insurance companies in order to help patients access expensive technology.
Yeah.
And so expensive technology can be anything from skin substitutes to the hepatitis C cure, or some of these more innovative gene therapies that are coming along today that could eliminate sickle cell disease and other hemophilia and other types of rare diseases that don't burden many people in the population, but of course, they're serious conditions that are debilitating, if not fatal, for many of the individuals who face them. And so the challenge right now is these technologies cost $1 to $2 million to implement on the group of patients who would benefit from them. That's a difficult balance in thinking about why does it cost so much? Well, the reason here, of course, Ira, is that there's a lot going into the investment in developing these technologies that I don't think many people appreciate. A single pharmaceutical grade clinical trial costs $20 to $30 million today to run. When you consider that for each successful technology that reaches the market, there are multiple failures that a pharmaceutical company had to take a risk on in order to see what could be the potential possibility of a technology to treating patients. And so when you balance those successes against the risk loss equation of a pharmaceutical company, and of course the marketing and other investments that they have to make throughout the R&D process, they spend about $2 billion on each drug that they bring to market. And so that money needs to be recuperated somehow. And of course, if you develop a technology like a gene therapy that costs $1 to $2 billion to develop, and the patient population for a rare disease only has several hundred or several thousand patients in it, and you have to price a technology at $1 million in order to treat 2,000 people and hopefully make your $2 billion back. That's how these businesses run. And so then the question now becomes, can we afford as a society, think of all the money that we have in the US GDP that is revenue from taxpayer dollars to pay for Medicare and pay for Medicaid. Can we afford as a society to pay for 30,000 patients with sickle cell disease to have a $1 million or $2 million technology? It's a tough question to answer. And it goes back to my point before on, well, there's opportunity costs to this decision, right? Because if we spend it in one place, then maybe we cannot spend it in another. What I've shown using some recent calculations is that the insurance models don't really work anymore for these kinds of technology, because the truth is, if you gave everybody access to the gene therapy for sickle cell disease in a risk pool through a Blue Shield of California or Blue Cross Blue Shield of Illinois or Medicare program, then you would potentially bankrupt some of these risk pools in local payer accounts. So that's a challenging proposition. But what I can show you using math from the financial market, using a typical housing mortgage calculation, you could actually afford to pay for these technologies using a mortgage model. That $1 million for a drug is no different from buying a house in California these days, or many other places for that matter. And so if we financed as a society, coverage for sickle cell gene therapy over 20 to 30-year mortgages at a low subsidized mortgage rate or interest rate, it would be more cost effective to pay for that and have people healed from these diseases being able to work more productively at their jobs and not facing the consequences of disease than not paying for it at all. And so something like a mortgage model through the financial industry presents an opportunity to help cover these new health technologies, put people to work in the United States, and actually that would help grow our GDP by having more productive people. You know, our strongest asset in the United States, of course, are the people who work here. And our economy will grow more if we have fewer people who are sick and facing the consequences of their own diseases. And so it would actually be to the financial market's interest, costly gene therapies using a mortgage model, than to deal with it through the insurance market, because they would end up being able to better predict growth in our overall economy over the long run. So that's one thing, of course, that we've been working on lately. I think it's really interesting because it invites a new sector of our economy into healthcare to work with us to help invest, and they will see returns on their investment over the long run, being able to predict better growth in the economy. Other things that I'm working on besides that one right now, I spent a lot of time, of course, trying to show the value of vaccines in our economy. I actually wrote a book that got published a year ago on the economics of vaccines and how to do calculations of economics and for that category of health technology. And I think we've come a long way, especially because of COVID-19. We've thought more about the value of these vaccines in the same light that paying for them is a better deal than paying for the outcome of an infectious disease. The challenge really is now is investing in the infrastructure in order to be more efficient at delivering vaccines. And we saw that during the COVID-19 pandemic as well, is that in the absence of an established infrastructure, it was an all-out panic at certain points in time, seeing who could get the vaccine and when. And so part of my work today is helping decision makers and helping governments realize that they need to make investments now in these infrastructures, and those investments are cost effective, that you'll receive a return on your investment as infectious disease continues to remain a risk in our society. And so it's not just the United States, but I'm working with countries in sub-Saharan Africa and Southeast Asia and in Latin America to do this as well. You know, what's interesting, Ira, is compared to the United States, where you had a lot of people who welcomed in the COVID vaccine, of course, that many people took it. And you also had a large arm of the United States that said, I'm not going to take it. And, you know, everybody's allowed to do what they want. I just find it interesting that in Africa, they've seen the consequences of infectious disease, for instance. They know what it's like to lose a family member to Ebola or Marburg disease or yellow fever. And so when you introduce an opportunity for them to invest in vaccines, it's almost across the board. They all say, let's work this out because it's too important not to go this direction. And so figuring out the economics of vaccine delivery systems, it has been a large success there, that they have a lot of momentum moving in that direction. And the only thing holding them back, of course, are the literal finances, because they don't have the same amount of money to invest in infrastructure the way the US does.
Absolutely. No, it's an amazing set of interests and topics that you get to think about, Bill. While I have you, I just wanted to ask one other thing. I mean, this is, I guess it's somewhat related, but I was really intrigued. Well, obviously, you know, you're at a pharmacy school. I was trained as a pharmacist originally.
Right.
You know, I remember, you know, back in the day, you know, our professor was telling us, your job is not going to be about putting pills from big bottles into little bottles. It's, you know, going to be much more. And pharmacy obviously has transitioned tremendously since, you know, I graduated in 1991. You wrote this interesting paper in Medical Care in June of 2021. Entitled "The Impact of Adding Pharmacists and Comprehensive Medication Management to a Medical Group's Transition of Care Services," again showing sort of the importance of the pharmacist's role here and what they can do in terms of preventing readmission for a variety of things. Can you say a couple of words about the importance of a pharmacist in this whole equation in terms of...
Oh, I'm happy to. And I know my dean will be happy if I talk a little bit about this paper. Well, this goes, Ira, to the general idea. Of course, we have a shortage of doctors and nurses in the United States, and that's going to result in many things. It just means that a person who lives in a rural part of the country may have less access to getting the right doctor that they need, time that they need it, or the same for as it would be with the nurse. The one thing that we seem to have a really good supply of these days is CVS and Walgreens and you know, pharmacies on every corner. And I appreciate this because I did my PhD in a school of pharmacy. I work in a school of pharmacy. So I observe the training that a doctor of pharmacy gets, and it's as intensive as medical school, right? Or dental or anything else. That a pharmacist has to learn about the entire human body. They have to learn about all the different types of medical conditions, and to think about how to treat it with respect to understanding pharmacokinetics and pharmacovigilance and all these other factors that go into treating disease. And given that there's so many retail pharmacies in the United States, we have the opportunity to make pharmacists the gatekeeper in many places for providing healthcare, that they can be part of helping to identify conditions and helping patients navigate care pathways to receive the right treatment for those conditions. And so I think it's an opportunity, like that paper highlighted, to show the value of the pharmacist, of course, in community and family medicine, and that where there are limited resources for other types of providers in a local area, that the pharmacist can be the quarterback, let's say, to helping the patient navigate the healthcare system. That doesn't mean that pharmacists should be the ones necessarily providing a hip replacement, but that they can be part of the solution of helping the patient navigate to get there at the right time if they're facing chronic arthritis conditions. So I hope that over time, in fact, that reimbursement policies, that Medicare, that other groups get more involved in thinking about the role that the pharmacists and other types of providers can play in managing community health and family health and medicine across the United States. What I see that has always been one of the biggest barriers to making that a reality, of course, are the medical boards, that the American Medical Association and local state medical boards, of course, they're very territorial and they're very conscious of not letting other professions into the field that has commonly been for a physician, an MD or a DO. And so that's really challenged the ability to expand coverage through multiple providers for individuals. But I think if we can get past those hurdles and allow types of doctors, including pharmacists and the like, to treat patients the same way that an MD or a DO would, then we have a better opportunity at managing health for the entire United States from corner to corner.
Absolutely, absolutely. And with everything that we've been seeing now, also with sort of the entry of some of these pharmacy chains into the clinical trial business as well, it's going to be it's been nice seeing it evolve beyond where we were a few decades ago. So that's exciting. And again, I do appreciate that paper as well. So very elegant. Really, really great stuff, Bill. I mean, I appreciate you walking us through all these topics. Again, some that we don't normally get into and really doing some hand holding here. But yeah, wishing you the best with not just the work at the university, but the consulting and continuing to focus on these these defects in value and the trillions that we potentially could be saving as a country. Again, for everybody that is going to be watching this episode across on our YouTube channel or across the various podcast networks. Again, you've been spending time with Dr. William Padulla, Assistant Professor of Pharmaceutical and Health Economics, Fellow, Schaefer Center for Health Policy and Economics, Alfred E. Mann School of Pharmacy and Pharmaceutical Sciences at University of Southern California. Also, we'll put the link into Stage Analytics, which he is a co-founder and principal at. Bill, again, thank you for taking time out of your schedule to educate us on all these topics. Obviously, thank you for what you do on all these fronts. And as we like to say on our show, thanks for helping to create a safer, a better tomorrow, a more cost-effective tomorrow for all of us. Really, really a great story, and I wish you the best with all your work.
My pleasure, Ira. Thank you for having me again, and it's really nice to talk with you today.
Great having you.